Interview to Professor Luigi Migone, following invitation by Professor Stuart Cameron. Professor Migone is a professor emeritus at the University of Parma, Italy, and former director of the Department of Internal Medicine and Nephrology. Professor Migone, how did you take up medicine? What was your background?
A memory takes me back to the old times, which seem so far, because the difference with the present world grows day by day. Choosing medical studies was not due to a careful documentation. It resulted instead from a combination of subjective reasons and vague aspirations to understanding patients in relation to their human aspects and scientific knowledge. At the beginning, I could not foresee how my choice would subsequently develop. But if I am asked to trace my cultural background, I should say that the classical studies before university left their mark, although they were not of immediate help in biological research. At that time, those who undertook experimental approaches met remarkable difficulties, because they were not prepared to them by preceding education. Teaching provision did not allow adequate methodologies, and students had to conquer them through trials and errors. My studies in the first postgraduate years were based on a personal decision to find the clinical applications of biological principles, a field that was somehow suspended between the past and the new perspective of the future. Anyway, the fundamental importance I gave to the approach to patients remained the source of any deeper investigation on diagnostic and pathogenetic purposes, which led to nephrological science.
How could we track your initial career achievements, your critical opinions?
During the first quarter of this century, and until the eve of the Second World War, the influence of German medical culture was prevalent in Italy. As far as pathology, pharmacology, and clinical science were concerned, I was studying learning on renal pathology, together with Follard, but this matter was included in the Unitarian field of internal medicine when I had to fulfill my clinical experience. Therefore, I was involved in other types of research, such as carbohydrate metabolism, treatment of diabetes, liver disease, clinical electrocardiography, hemochromatosis, hematology, etc., in different periods of time.
How did you first came to what we now call nephrology?
The constant observation of patients, in spite of the environmental restrictions of the Second World period, led my first studies on renal pathology, starting from the renal involvement of systemic polyarteritis nodosa. The subsequent widening of this experience allowed me to investigate deeply on vascular nephropathies with the secondary hypertension, related glomerular lesions, and malignant nephrosclerosis. Besides, I devoted myself to clinical investigation on renal failure with an accelerated and irreversible cause, such as in pregnancy, preeclamptic toxemia, infections, and shock, through studies on another form of vascular pathology of the kidneys, which I defined as acute thrombotic angiopathy with bilateral cortical necrosis, further included in the pathogenesis of the intravascular coagulation. My experience on other cases of acute renal failure was later extended to the histopathogenesis of a glomerulonephritis now defined as rapidly progressive, which I analyzed at the time, especially in the glomerular capsule and its exudative, proliferative, and fibrinoid necrotic processes. In this way, I was able to trace a form indicated as capsular acute glomerulonephritis. On the other hand, my interests on systemic vasculitis included, towards the end of the 40s, the first observations in Italy on temporal arteritis and the pathology on renal glomeruli in lupus erythematosus. In the latter case, I described a syndrome which at first I called malignant erythematovisceritis, and I included in my studies on systemic connective tissue diseases, compared with international contribution on their clinical, immunological, and therapeutic aspects. These exams enlightened me about nephrology, with all the subsequent developments, not only on the morphological aspects, but also for the larger field of functional manifestation.
What might have altered the track of investigation? What held back or promoted clinical and investigative thought and action at that age?
Before the Second World War, physiology in Italy, although promoted by outstanding personalities, was not specifically directed toward the kidney. And most clinicians did not take into much consideration single functions, but only global evaluations already investigated by Follard on urine concentration and dilution, or limited to urea clearance, disregarding the importance of the glomerular filtration rate, although Reber's achievements on creatinine clearance for measuring this function date back to 1926. Only at the beginning of the post-war period, I was able to take advantage of Addis, Ellis, and other contributions on glomerulonephritis. But particularly Homer Smith's fundamental work, known at the beginning of the 50s, was a crucial turning point for the knowledge and measurement of circulatory, secretory, and excretory function of different segments of the nephron. In an original alliance between physiology and clinical medicine that led to important progress for all nephrological studies. Further on, my personal experience was also directed to functional disorders such as diabetes renalis, or renal diabetes. As far as the renal blood circulation is concerned, I cannot forget to mention the research dating before the 50s of the intrarenal blood redistribution and the cortical ischemia, and the discussion of the experimental so-called Trueta shunt towards the medulla, linked with the acute renal failure in the pathophysiology of shock. Starting from a different methodology, further advances were more acceptable with Oliver's investigations on nephron dissection and the localization of toxic and ischemic lesions in different tubular segments. I quote only this field of research. For my studies on symmetrical cortical necrosis and for the experimental investigation I performed with my collaborators on tissue, biochemical, enzymatic changes, and in particular in the kidney during the shock of crash syndrome.
Concerning the separate functions of different tubular segments, could you comment your diagnostic and therapeutical experience?
I used to follow the measurement of osmolar clearance, free water clearance, sodium and water reabsorption, osmotic diuresis, and solute-free diuresis, studying many classes of diuretics, beginning in the early 50s with acetazolamide, the first thiazides, furosemide, and other new agents. The effects on water electrolytes reabsorption of different nephron segments were investigated from the proximal to the loop and in distal tubule. In this way, the diuretic drugs and some hormonal interference, such as spirolactones, aldosterone, ADH, were considered not only for their therapeutic effects, but also for the possibility of using them as tools of research on tubular ion exchange.
In order to maintain a connection between clinical and experimental investigations within your unitary concept of nephrology, did you carry on further approaches to renal physiology?
This is an ambition I already had at the time of my study on diuretics, thanks to the collaboration of researchers in the field of general physiology, such as Vittorio Capraro and Franco Marro of the University of Parma and Milan. In vitro investigations were performed on the electrolyte transport and the permeability through frog skin. In later years, I was attracted by the physiological research on tubular reabsorption and on hemodynamic functions at glomerular level performed by micropuncture techniques in experimental animals. This was possible through the work done by my collaborator Vittorio Andreucci in Dallas at the Department of Donald Sandy and Floyd Rector at the beginning of the 70s and continued in Parma for the first time in Italy with original contribution.
Could you now give us a hint at the main steps of your way towards the present issue of clinical nephrology from the time of your initiative of the Italian Society of Nephrology?
In the second half of the 50s, the first National Society of Nephrology were created in England and in France. When in 1957 I promoted in Parma the foundation of the Italian Society of Nephrology, the nephrological studies initiated their major development and grew progressively throughout Italy during the 40 years that followed, with important contribution not only at national but only at an international level.
And what would you say about the foundation of the International Society of Nephrology, where you served for a long time as the only Italian representative till the office of Vice President?
At the beginning of the 60s, the International Society of Nephrology was also created, thanks to the initiative of Jean Hamburger. At that time, the first International Congress took place in Evian, together with the first Executive Committee of the Society, where I took part as the representative of Italy, together with Gabriele Monasterio. During the following 15 years of my participation in the committee, the science of nephrology had been developing as a new discipline, whose roots were in internal medicine, while new advances in pathophysiology of renal diseases also involved many biological functions related to homeostasis of the whole organism.
How did you face the new technical and social problems involved in dialysis treatment?
After the early experience with hemodialysis in acute renal failure, dating from the second half of the 50s, realized that a new era was opened by chronic dialysis with the Scribner-Quinton shunt and the arteriovenous fistula of Cimino Brescia. Two of my co-workers, Vincenzo Ferioli since 1965 and Vincenzo Cambi since 1969, respectively, spent 2 years of fellowship in Lyon with Jules Trager and Seattle with Belding Scribner to improve the experience on dialysis technique and modalities of treatment. In Italy, the first application of chronic dialysis treatment was difficult because hospitals were not prepared and administrators were diffident towards a life-saving therapy that was carried on only in a few pioneering centers. In the 60s, my group in Parma had to work for hemodialysis in hard conditions because of the crowding of patients coming from different parts of Italy where hospitals were not ready with new technology. Besides, adopting peritoneal dialysis as it was already performed in Seattle with the silastic catheter created by Henry Tenkov, we are able to treat a greater number of patients, and this alternative treatment was later developed by Giuseppe La Greca. In fact, after the 30 years marked by incredible efforts, but also rich of new discoveries, the technique of continuous ambulatory peritoneal dialysis and the general achievements of nephrology made it possible in the 70s to reorganize many dialysis centers.
Did you ever feel that these unexpected achievements could have altered the initial perspective of nephrology?
In the second half of the 60s and in the following decade, research that was carried on with the purely scientific purposes clashed with the experience of chronic dialysis. We thought that the new discipline of nephrology could become the sole dominion of new professional figures, the dialysis operators, whose technical ability was precious, but without aiming at scientific research. Economic interests appeared and created further confusion, while the prevalence of the poor facilities and financial resources could be diverted to technical demands. The problem was not limited in Italy, and discussions were going in Europe, so that we for a moment felt the risk that medical science and technique, nephrology and dialysis could part their ways.
In relation to these problems, what about your experience as a council member and president of the European Dialysis Transplant Association?
Since my participation in the European Dialysis Transplant Association in the second half of the 60s and later with my involvement in the council, I was aware of the importance of joining dialysis and transplants activities with renal physiology and clinical nephrology. Just on the occasion of the annual EDTA Congress, which I presided over in Florence in 1972, for the first time in Italy, these intentions were confirmed, but became officially only in 1982 under the presidency of Vittorio Andreucci. Finally, the new constitution voted in 1996 was entitled to European Renal Association, preceding the classical EDTA wording in order to indicate a crucial significance of an historical evolution.
Along with this progress of knowledge on chronic renal failure, we would like to comment on your experience of conservative and dietetic treatment.
It is well known that this treatment is strictly associated with the problem of diet, to which Italian nephrologists, Carmelo Giordano from Naples, Gabriele Monasterio, Sergio Giovanetti, Quirino Maggiore from Pisa, Giuseppe Masco from Padua, Guarienti from Trieste, and others have given original contribution. Now I'd like to mention the investigation of Giovanni Garini and other members of the Parma department on the slowing effect of low protein diet on the progression of chronic renal failure. Under these conditions, a preservation of nutritional status, serum protein levels, and nitrogen balance has been demonstrated, together with improvement of endocrine and metabolic disturbances, and correction of several amino acid content of muscular tissues. Above all, the importance of the compliance of the patient has been stressed, such as it is realized with various and acceptable diet preparation when minimal vegetable protein content is supplemented with amino acids. One may add that these effects are conditioned by preceding nutritional status, age of the patients, level of renal failure, duration of treatment. Therefore, the alimentary components should be adapted to different clinical influences, such as a variation of protein requirement or utilization caused by uremic derangement, catabolic episodes, infectious complicating. In a different condition, such as nephrotic syndrome, the same group of Garini showed that the protection of renal function could be maintained, but with higher protein content, providing that angiotensin converting enzyme inhibition is associated to improve renal circulation. As far as other possible mechanisms of diet are concerned, I could quote the hypothesis of a stimulation of protein synthesis from intestinal ammonia liberated from urea substrate of the enlarging nitrogen uremic pool. This anabolic process was previously demonstrated outside of uremia only in malnourished children and growing rats. But one had to know whether in chronic uremia ammonia liberated from intestinal urea degradation to portal circulation would be reabsorbed with urea at a greater extent, while it is known that urea cannot be directly utilized for resynthesis process. The research I carried on with my co-workers on experimental rats under chronic uremic conditions from subtotal nephrectomy showed an increase of portal uremia without any significant increase of portal ammonia in comparison to normal. Whereas in acute uremia, brought about by bilateral urethral ligation, a significant increase of portal ammonia was evident, being equal the blood level of urea in most experimental conditions. These data are in accordance with the relationship between chronic uremia and inhibition of ammonia reabsorption from the gut, so that its utilization for protein synthesis would not become possible. Our data agree with those of Tizianello and De Ferrari from Genoa on the lack of any increase of portal ammonia and amino acids in men with chronic renal failure. In addition, we could show in chronic uremic rats a significant resumption of ammonia reabsorption and aldosterone inhibition with potassium canreonate. In fact, hormonal factors such as an aldosterone excess, among other metabolic disturbances of chronic uremia, could rule out an anabolic effect of low-protein diet. But I cannot now go into details of facts and hypotheses involved in this long story.
Could you now comment your experience on the main technical improvement of dialysis related to the physiopathology of uremia?
Cooperation between bioengineering and clinical experience became more and more active in the mid-60s. Since that time, I could follow the research initiated by Scribner and Babb through the participation of Vincenzo Cambi in the Seattle team. One aimed at identifying the metabolic products accumulated in the course of uremic syndrome and partially removed by dialysis, and particular importance was given to substance of middle molecular weight instead of limiting uremic toxicity to urea, potassium, phosphorus, and acid metabolites. This hypothesis originated the so-called square meter hour hypothesis and later to middle molecule hypothesis. In fact, it was observed that peripheral neuropathy was less frequent in peritoneal dialyzed patients, probably because of better removal of uremic toxins of middle molecular weight from the greater surface area and permeability of peritoneal membrane. New technical devices were prepared, changing flow of blood and dialysate flow in extracorporeal circuit, increasing surface area and permeability of dialysis membranes, and time of treatment, modifying composition and ultrafiltration of dialysis fluid. Considering my participation to the new events, I mentioned the short dialysis successfully developed by Vincenzo Cambi, and the new research which I initiated with Paolo Dall'Aglio and later Carlo Buzio and other co-workers on the isolation of middle molecules from uremic blood. Our purpose was the identification of solutes responsible of the uremic toxicity, which could be removed by dialysis treatment. Further on, the investigation performed in the same department by Giorgio Savazzi on peripheral nerve conduction velocity gave significant contribution to testing uremic toxicity and related influence of dialysis treatment. Now, I have to confess that the current results hint a retention of many substances, each one non-specific nor limited to a particular molecular weight. The pathophysiological effects may be variable with the long lasting of uremia and this treatment, but all the mechanisms of uremic toxicity are not yet completely understood, while effects of biocompatibility of dialysis membranes, including cytokines, oxygen radicals, are under investigation.
From the beginning of your official responsibility in nephrology, how did you predict or directly plan an interdisciplinary organization of your clinical service?
Long survival by dialysis treatments remove the initial fear of a technical overwhelming because it caused new discoveries and experience in the field of chronic renal failure and internal medicine. Nephrology became a subspecialty with very strict relation with all disciplines in the medical field. At the very beginning of my official appointment, there were no problems because the nephrological activity was included in a medical clinic comprehensive of all branches of internal medicine. The clinical experience with different patients enabled me to study renal, circulatory insufficiency during heart failure, and particularly the pathogenesis of hepatorenal syndrome concerning circulatory, tubular function, and various responsiveness to diuretic and other means of treatment. Other studies included analgesic nephropathy and its epidemiology, clinical and morphological aspects of pyelonephritis, and therapeutic research of urinary infection and renal stones. Further on, I'd like to quote immunochemical studies carried on by Rosario Mallorca and Lino Scarpioni on serum, the urinary proteins, and related diagnostic of different kinds of proteinuria and monoclonal gammopathies. As far as glomerular nephropathies are concerned, my work has been developing with increasing practice of renal biopsy and related immunohistological research. In fact, I chose to organize together three main subspecialties which seem to me at most interrelated: nephrology, clinical immunology, and medical genetics. For the histopathology, I am indebted to the early assistance of Giorgio Olivetti from the Institute of Pathology of Parma University, and more recently to my co-worker Landino Allegri and his research on autoimmune glomerular pathology. And I cannot forget to express my appreciation to the essential contribution to clinical and histological research of Stewart Cameron, to whom I am very indebted, Robert Heptinstall, Madame Habib, Priscilla Kinker-Smith, and Italian nephrologists such as Giuseppe D'Amico, Luigi Minetti, Claudio Ponticelli, and their groups in Milan, and many other well-known, very distinguished colleagues. Genetics is now in Parma proceeding under the responsibility of Mario Savi, dedicated to molecular bases in relationship to histocompatibility for kidney transplantation and to hereditary nephropathies. A further enlargement of the department has now included, with Innocente Franchini, the discipline of preventive medicine. An example of the interactive work I tried to keep in the Institute of Medical Clinic of Parma, I presented an invited lecture at the National Congress of the Italian Society of Internal Medicine, with my first and May co-worker Alberico Borghetti, for an extensive report of our experience on the pathophysiological and clinical aspect of renal failure. This work included the participation of 16 members of the same institution. And here I'd like to quote among those collaborators already mentioned in this interview and elsewhere, Alberico Novarini for excellent contribution, and Giorgio Cocconi for the study on hemostasis.
Did you have a particular recollection of human and scientific relations?
Here, overwhelming memories of people and events are surrounding the course of my long experience in the field of nephrology. Beside people and facts I have already mentioned, I cannot forget some friends of mine I met outside Italy, such as John Merrill, for his original and pivotal contribution to the conservative management and dialysis therapy of renal failure. Gabriel Richet, from the great school of Jean Bourget. Paul Mikkelsen, an important expert from Lovanium in kidney transplantation. Nils Hallwall, from Stockholm, the pioneer of the artificial kidney since the 40s. Jan Brod, who organized an early congress of the International Society in Prague, but had to leave his country in 1970 due to political events, and several more people, such as Walek, who remained in Prague, Hans Sarre, and heir of Franz Fowler, Tadeusz Orlowski, and Sigmund Aniszki, two generous Poles. Hugh de Wardener from London, who went deep into new aspects of renal physiology. Arthur Kennedy from Glasgow, the first EDTA president in 1972-75 period, after a new constitution we had prepared in Barcelona with Emilio Rotelar and all the council members. I remember also Bruno Watzinger from Austria, who gave a substantial contribution to the beginning of the hemodialysis therapy. And Jan Bergström from Stockholm, who investigated uremic toxicity. And many more friends, whose name I am not here the time to list, as I'd like. They increased my scientific and human experience. Now I'd like also to remember some international meetings I had the opportunity to promote periodically for several years through personal contacts. First of all, every year for a long time, eminent colleagues came to Parma from the main European and American centers to discuss about the main current topics on nephrology. As a second example, an annual triangular meeting was organized during 10 years in Lyon, Bern, and Parma, respectively, by Jules Tréger, François Roby, and myself, in turn, in order to present the personal experience and that of our medical staff. Individual opinions could be directly compared and current research freely discussed, all times.
Considering that a significant part of the time you spent studying clinical and morphological aspects of nephrology is reflected in textbooks of nephrology and the monographs on glomerular nephropathies, would you now give your more recent impressions on the actual spreading and predictable evolution of this kind of pathology?
My recent comments concerned epidemiology of glomerulonephritis. In fact, social and economic status, crowded dwelling houses, and poor hygienic conditions result in diffusion of infections. On the other hand, antimicrobial therapy has changed the course of several forms of glomerulonephritis that were considered as irreversible. Dramatic effects appeared for cases of glomerulonephritis classified as primary ones from clinical point of view, but eventually included in a secondary pathology on the basis of etiologic investigation, tumor infection, and so on. Consequently, new means of prevention and therapy have been achieved. In addition, the role of toxic factors related to industrial pollution should be investigated. Furthermore, we have followed the effects of immunosuppressive therapy causing a complete reversal on the prognosis of some autoimmune renal disease. The lowering incidence of post-streptococcal glomerulonephritis, mainly remarkable in our countries, was compared with its persistence in the less developed world, and possibly related to a nephrogenic streptococcal strain carrying an endocellular antigen which Lange called endostreptosin. And we test through chromatographic identification and its specific antibody response. In any case, a progress in the epidemiological investigation for many types of glomerulonephritis is mandatory by considering different strata of population and geographic areas.
In your experience on the clinical course of many types of glomerular nephropathies, did you find suitable criteria of their possible evolution?
I have been particularly interested in this subject. Therefore, I would like to stress my concern about asymptomatic patients presenting with mild and isolated urinary abnormalities. Under these circumstances, it was difficult to verify if the real tendency pointed toward healing or a progressive worsening. Due to the above, an extensive research was planned and carried out on the renal patients of the department for many years, regularly measuring total protein excretion and albuminuria after immunoelectrophoretic detection, even at minimal quantitative levels, as persisting from the beginning of after an acute nephritic syndrome, such as post-streptococcal. We showed that the pathological isolated albuminuria in ortho and clinostatism, or only in clinostatism, was related to glomerular mesangial lesions, even with normal levels of total proteinuria. Normalization of albuminuria resulted as a more suitable index rather than total proteinuria for the assessment of recovery. This outcome was confirmed after a long follow-up or by normal histology or negative immunofluorescence. On the other hand, persistent pathological albuminuria was followed by pathological values of total proteinuria, after a variable period of time in cases of worsening evolution of the nephropathy. This method, revealing subclinical glomerular damage, allows identification of patients who need a follow-up, even if renal biopsy is not repeated. Parallel investigation on total proteinuria and albuminuria of normal individuals was carried out by Carlo Buzio and other co-workers of mine in relationship to distribution of normal dates, protein load, and circadian rhythm. A further extension of these studies has been more recently continued by Buzio, Borghetti, and other members of the department on hypertensive patients under high protein diet with glomerular filtration rate but reduced renal reserve. One could show that the calcium channel blockers, but not angiotensin converting enzyme inhibitor, raised glomerular filtration rate, renal plasma flow, and protein excretion by acting on glomerular selectivity and tubular reabsorption. Besides, differential excretion of single fractions of proteins and their quantitative interrelations were measured and compared with the degree of glomerular and tubular lesions in several renal diseases.
Now, we would like to enter the subject of transplantation, which cannot be separated from the main achievements of the bulk of nephrology you have been talking about. Do you have a comment on eventual problems you had to meet in your personal experience?
It is well known that cadaveric transplantation depends on a strict collaboration with intensive care units in finding and preparing available organs. No transplantation is possible if this collaboration is deficient, even if surgical and nephrological facilities are effective. Perhaps an inadequate involvement of intensive care units to this activity still persists in some parts of Italy and causes a low kidney procurement, so that several people must address their request to the transplant centers which are active in different territories of the country. The other problem is dealing with the consent from the donor's relatives. The possibility of refusal depends on cultural levels and local traditions. However, these difficulties may cease if the matter is brought to an adequate attention of public opinion and people are correctly informed, in order to avoid any misunderstanding about the identification of brain death to the death on the individual as a whole. A real education should clarify the groundlessness of certain opinions coming from some bioeticians and philosophers too, who question the definition of cerebral death. According to this opinion, someone still agrees with transplant, though thinking organ donation anticipates death, which they assume would only correspond to cardiac arrest. Therefore, donation would be a lethal intervention, I would say a particular case of active euthanasia. Against these baffling opinions, it is important to confirm the validity of the concept of brain death that corresponds to the real death, even if some isolated vegetative and neuroendocrine activity occasionally persists in patients who are only apparently alive under artificial cardiopulmonary assistance. Moreover, some insinuates the suspicion that the short number of transplantations in same regions depends on the potential interference on this treatment, on the business related to dialysis therapy. However, I think that this hypothesis does not seem to be acceptable, because the number of patients who are eligible for kidney transplantation is too small to significantly affect the size of the increasing dialysis population. Now the problem of living donor transplantation is too big to be discussed here. I can say that comparing my opinion with those of philosophers, biologists, and ethicists, I do not expect nowadays the social response to this demand to go over the current level. However, new hopes about psychosocial feelings should evolve towards this extraordinary opening of human solidarity. This is my hope, at least.
Considering your election as honorary member of the European Renal Association, EDTA, and honorary president of the Italian Society of Nephrology, the golden medals of the President of the Italian Republic for the Public Health School, Culture and Art, and that one of the University of Parma, and other rewards, may one ask you how you consider your greatest accomplishment and satisfaction?
It's a difficult question, because I am aware of my limits, about the goals I could not reach and the opportunities I missed. I do not like to talk about degrees of satisfaction, because I do not want to judge the credit I can take from my results. However, the regret for what I could not bring to an end could be cancelled if members of my department, students, pupils, or patients still consider as valid the lines I have suggested. The great number of co-workers of mine that had the opportunity to reach a key position in nephrology units of university and hospitals throughout the country helps me to hope for a continuity of an advancing progress. And it is enough to justify my job.
Your prediction of the future of nephrology.
This again, another very difficult question to have a look to the future. I can say that in the field of renal pathophysiology, the progress of current studies on gene expression of vasoactive hormones such as angiotensin and endothelin will allow to know better the effects of vasoconstriction and also of hyperplasia and hypertrophy of mesangium on glomerular permeability, protein excretion, and sclerosis, with the participation of mediator of inflammation, cytokines, and autocoids. With regard to transplantation, the improvement of immunology and the possibility to induce a tolerance of genetically unrelated organs without the help of immunosuppressive therapy are realistic goals, even if they are limited by the small numbers of living or cadaveric donor organ. A possible solution could be offered by xenotransplantation, if the new transgenic science can offer real possibilities to control the rejection. In any case, one has to face the unexplored field of hybridism and chimera at the edge of genetic identity of the human being and the possible danger of still ignored infections. Gene engineering would probably allow to implant a erythropoietin gene into an endothelium or muscle cells near the vascular access of dialysis patient. And this will probably solve definitely the problem of anemia. On the other hand, since calcium sensing receptor proteins of parathyroid glands have been already cloned, the corresponding genes will probably be utilized to restore the calcium sensitivity and correct hypercalcemia in some forms of secondary hyperparathyroidism. Other attempts to utilize gene engineering will consider the possibility to introduce normal genes in order to substitute the lacking ones in the renal polycystosis and other associated hereditary kidney disease. Further on therapeutic molecular modulation of genes involved in the synthesis of factors related to expenditure of mesangial will be studied in order to slow the progression of glomerulonephritis. Cell therapy will probably be introduced in assembling an artificial kidney, more effective than current dialysis machines, by spreading out endothelial cells on artificial filtering membrane. Cells previously isolated and cultured in vitro will be engineered to produce anticoagulant factors and mesangial substances. At the same time, isolated and cultured epithelial cell will be implanted into hollow fiber device after the introduction of genes coding for spatial function of water and solute transport. But I cannot go further. In conclusion, the way toward the new conquest leads to two different targets, both important but in contrast with each other. That is, the increase of expectancy or of quality of life. According to a new topic aspiration, both targets could be combined, but in practice they are conflicting, and the selecting pathing between these two medical interventions is often unavoidable. In the years to come, probably sooner than it can be predicted, the question will arise about the limits of the currently increasing role of artificial means, biotechnology and transgenic science, not only for radical treatments, but also for potential changes affecting the debated definition of life. New duties and responsibility are emerging at the horizon, and they have to be shared with the whole social context, getting over the limits of scientific research. In this scene, interdisciplinary resources should allow a comprehensive solution of an old but still impending problem, once opposing nature against culture, and today the spontaneity of life against the intervention of science and technology.
Last question. Since your retirement from the university's duties because of age limits and your nomination as emeritus, did you leave the nephrological activity or are you following other cultural interests? How could you redefine your latest work?
My studies on glomerulonephritis could not possibly cease all of a sudden. And I also examined new metabolic aspects of diabetic nephropathy and related diet therapy in comparison with early achievements which I met at the beginning of my career. Today, the field of bioethics has caught my main interests. I believe that after a long time of full immersion in the empirical investigation of facts, it is time of addressing the cognitive function to find out the criteria which are involving the fundamental choices. For some years, I just considered the search for values, for significant values, as an important duty, in order to justify the lines of action. Therefore, I have adopted an epistemological approach to the modern issues of science, also including the impressive explosion of interest about bioethics and medical humanities. I have considered the concept of life and death in the current of evolution of biology and medicine, and the ethic of transplantation in relation to criteria of brain death and the meaning of artificial cardiorespiratory assistance. In this connection, a critical approach to the development of biotechnology seems to me as necessary to reevaluate ethical principles. I feel that traditional rules of objective rationality and acceptance of a transcendence are at a confrontation with the claims for subjective autonomy of human beings. I now attend to debates on medical care at the end of life and voluntary euthanasia proposed as an aberrant physician-assisted suicide. Moreover, I have studied the new and worrying phenomenon of voluntary dialysis withdrawing or withholding with relation to decision autonomy of the patient, physician's duty, and liberty of conscience. Finally, I entered the problem of allocation of scarce medical resources, which is deeply involving the whole society. And in the field of nephrology, this choice was distressful in the past, when the shortage of dialysis machines could not meet all the increasing needs. Today, this problem has been solved in Western industrial countries, but not yet in the greatest part of world population, where even elementary resources for basic means of sustenance get out of hands. Furthermore, the response to the demand for transplantation is far from adequate everywhere. History is continuous moving, and we have to face an unpredictable evolution. As for me, I will try to go on my way as long as I can.